the grade of the speakers. Going back to the base, I think this is the most important talk because without this knowledge, you wouldn't be able to do all the things that came before. So, totally free to talk about anything here, okay? It's all about sheaths, wires, and catheters. Okay, it depends on what you want to do. If you want to use a score balloon, that's the thing you have to think first. So then I have to choose a 6F sheath. So that's the first thing. The second thing, you must know in advance what you're going to use and what you are going to put on the table. You have to standardize your treatments. They have to be cost effective, and they should be as simple as you can, having this lean concept from the industry. So we have to fight against these two endovascular facts. Number one, not two doctors use the same material in the same procedure. Fact number two, the same doctor uses different material in the same procedure. So let's see what we do. This is for the residents. It's a chart I made, so you can see that if we use 4F, we can do all diagnostic and low pressure PTA. With the 5F, we can do high pressure PTA. We can start using drug-eluting balloons. With 6F, we can do ultra-high pressure. We can start using score PTA. We can begin with thrombectomy. With 7F, we can do central venous PTA. We can do thrombectomy, and we can use the first-time graft, the Viaban. And with 8F, we can do mostly all of the procedures. Normally, we're going to use short length sheaths. 5 centimeters would be optimal. Probably the most important thing would be the taper transition on sheath and dilator, and transradial sheaths from cardiology work really well in this area. Okay, this is a new thing that we have now, these thin wall sheath designs. It means, if they tell you it's a 5/6, it means that we make a 5F hole in the fistula, but we can use 6F devices inside. So I think it's something very good to use. This is another thing we use a lot, this kind of sheath, because when we finish a procedure, we want the patient to be sent to dialysis. We don't want to compress the fistula, so this can be used for temporary dialysis with a very good flow. Sheath positioning, nothing new in this audience, just 3 different things. You can go up through femoral with 100 centimeters sheath. You can use one sheath inverse for going upwards and going downwards. Or this last thing we are doing, we are using the snuff box. So it's quite easy to puncture with ultrasound, and you can access both the arterial and the venous side with a very friendly angle. Purse string suture for the residents, taking care to put the suture in the subcutaneous, and you have some fancy gadgets like this knot retention device. Guide wires, we almost work with 0.35 guide wires, but in some cases we might use 0.18 guide wires, mainly if we are working with 4F platforms. If we are working with score balloons, we also use it. Some drug-eluting balloons, like from Biotronic, might go through these wires. Viabans go through 0.18. It would be the best initial tool if we are dealing with immature AVFs. And I would use it as a second option for steep-angled anastomosis. I would also use it as a second option for central venous CTO. So something we have to remind, it's some issues about guide wires. We have to refresh our knowledge about some concepts like tip load. We should have this wire selection chart in our heads, and just remind you that there are different techniques like sliding, drilling, penetration techniques when we are dealing with central occlusions. Just like to put other uses of guide wires, as in this case, we didn't have a score balloon, so with a 6F sheath, 2O14 guide wires, and a 4F PTA balloon, you can do a kind of score balloon. Catheters, normally it's very simple to navigate in the fistulas. You only need 2 catheters, a multi-purpose one, and a half curved catheter if you want to work near the anastomosis. Highly recommendable support catheters, Navicross, Cook CXI for central occlusions, and we usually don't use micro catheters. Okay, so let's apply this lean concept. How do we work? This is what I propose. For stenosis, we just start with a 5F PTA balloon and a 0.35 Terumo guide wire with curved tip. Option number 2 would be downsizing everything to 4F with a V18 guide wire. And for thrombosis, it changes a little bit. We use a 5F multipurpose catheter and a 0.35 straight Terumo guide wire, as you can see. You can mostly work like this very efficiently. Just a recommendation for crossing the anastomosis, just by giving this double bend in the V18 guide wire, you can cross almost all of the anastomosis. Some refreshment for all of us about balloons. We should know the difference between the tip entry profile, the crossing profile, non-compliant, hydrophilic, hydrophobic, all these issues that can help you from a technical point of view to cross difficult situations. And here you have an example. We are crossing with this shaped V18, and we are working with a BTK balloon with a low entry profile, crossing profile, with these characteristics, and then we are moving to a normal balloon, as you can see there. Central venous CT, we can, CTOs, we can go with big devices or small devices. Big devices support catheters like Navicross and a straight guide wire, and the other option would be small devices, mainly with CTO-loaded tip guide wires. Microcatheters, we don't use them, but I just put a case where we used to embolize collaterals. Nowadays, we embolize collaterals percutaneously with glue. And finally, the most important thing, it's the hand and the expertise of the physician. And here you can see all the maneuvers that we are doing during a thrombectomy. We enhance thrombolytic penetration by compressing with our hand. We shake, we massage to move the thrombus from one point to another one, sheath aspiration on Fogarty. So these are the conclusions. We have to master the technical specifications of the material, and we have to standardize our endovascular AFB treatment. Thank you very much for your attention.
Thank you very much.